This is a brain CT of a 69-year-old female patient performed without IV contrast administration. The reason the CT was done because the patient was involved in trauma. This is a sagittal reconstruction on the CT of the same patient. Now, before we look at that case, let me show you a few normal anatomical structures on this normal MRI of another patient. As we discussed before, this is an axial image of a T2 weighted MRI. The CSF is bright on T2. This here is the brainstem. Particularly, this part of the brainstem is the midbrain. The midbrain looks like Mickey Mouse. As you go lower down, you see the second component of the brainstem, which is the pons. The pons has what looks like a big belly. And going down from the pons, you'll see that you have this smaller component of the brainstem, which is called the medulla. So from above below, you have midbrain, pons, and medulla. This is a sagittal image showing the midbrain, pons with its big belly, and the medulla. Another thing to highlight is that the cerebellum is connected to the brainstem. This is your right cerebellar hemisphere, this is your left cerebellar hemisphere. And the component of the cerebellum in between both hemispheres is a structure of interest today. It's called the vermis. So the vermis is a central component between both cerebellar hemispheres. This is again a sagittal T1 where CSF is black. If you go to the side, you have a cerebellar hemisphere. As you go to the center, you see this. And this central cut shows you a part of the central cerebellar component, which is the vermis. To complete the anatomical components that I want to talk about today, let's talk quickly about the ventricular system. This CSF-filled component is the lateral ventricle on each side, on the left and on the right. The lateral ventricle opens through this channel here on the left and on the right, which is called the foramen of Monroe. This opens down to this slit-like area of the ventricular system, which is the third ventricle. And this third ventricular component continues with this rounded CSF dot here. It's a channel, which is known as the Cerebral Aqueduct of Sylvius. This opens finally into the fourth ventricle. Cerebral Aqueduct, which we'll nicely see on the sagittal images again, opens into this here, which is the fourth ventricle. Notice how the fourth ventricle is surrounded by the brainstem and cerebellar components. Let's look at these structures on the sagittal image as well. So to the side here you have the right and left lateral ventricular system. As we stop at the midline, remember the slit-like third ventricle should be located here. It's not easy to see since it's normal and not dilated. Then remember that elongated channel that we talked about looks like a dot on the axial image. This is the Cerebral Aqueduct of Sylvius, which connects the slit-like third ventricle with the fourth ventricle. Remember, the fourth ventricle is surrounded by the brainstem and the cerebellum. Now that we're more familiar with ventricular, brainstem, and cerebellar anatomy, we could discuss the case that we started with. So back to our case, the abnormality is obviously seen in the posterior fossa here. On a CT scan, the CSF spaces appear dark. This is how fluid in the brain would appear, and the density of this abnormality is similar. So this well-defined rounded abnormality in the posterior fossa has an internal composition of fluid that simulates CSF. Now we know we're looking at a fluid-filled cystic abnormality of the posterior fossa. To complete the description, you have to describe the effect it exerts on the surrounding structures. This abnormality displaces the cerebellar hemispheres to the side. You'd have to wonder of the status of the central component, the vermis that we talked about. And at this point, it's not clear if the vermis is replaced or hypoplastic versus displaced upward. Notice how this cystic structure compresses on the CSF space here, so it's likely compressing on the fourth ventricle. Given that such a finding may lead to impedance of the flow of CSF and secondary hydrocephalus, you have to comment on the size of the ventricles. I'll just tell you that the ventricular system here is of acceptable size for the patient's age, so there was no clear hydrocephalus. When you have a lesion of potential mass effect anywhere in the brain, and in particular the posterior fossa, make sure that there is no tonsillar herniation. On this cut, this is the spinal cord and this is the CSF that surrounds it at an area that we call the Foramen Magnum. This lower cut shows the spinal cord and the surrounding CSF in an area that we call the Foramen Magnum. If this were tonsillar herniation, you would have fullness of soft tissue in this location. Remember that the tonsils are the most inferior components of the cerebellum, and this is not the case here, so you do not have tonsillar herniation in this case. This is the sagittal reconstruction from the same brain CT. And as we go from side to side, you could see the lateral ventricular system here. This is the third ventricle, which opens through the cerebral aqueduct of Sylvius into the fourth ventricle. Looking carefully, you'll notice that this cystic abnormality has a separating thin membrane from the fourth ventricle. And the abnormality displaces the fourth ventricle from the inferior and posterior aspect. Going to the side, you see one cerebellar hemisphere. Going to the other side, you see the other cerebellar hemisphere. And going back to a midline image, you'll notice that this is the cerebellar vermis, the central component, which is complete. It's not absent, so it's not hypoplastic. The only thing that's happening is that it's displaced superiorly. Another thing to keep an eye on is, despite the presence of this abnormality, the posterior fossa is not expanded. And this area here that appears a little bit bright is a venous confluence that is known as the Trocular Herophily. The Trocular Herophily is not elevated by the effect of the abnormality, so there is no expansion of the posterior fossa or elevation of this. So if you have a pure CSF containing cystic abnormality within the brain, the most likely possibility would be something called an arachnoid cyst. So it's just a contained CSF composed cyst. Another differential diagnostic possibility for a CSF density posterior fossa structure would be a megacisterna magna. A megacisterna magna is usually an incidental variant of no clinical significance, and the location is that of a CSF space expansion posterior and inferior to the cerebellum. In this case, as you go from side to side, you don't have expansion of the CSF space in that location. You only have the cystic component that we described. The third differential diagnosis for such a finding is called a Dandy-Walker malformation. With Dandy-Walker malformation, you have a few components that are absent here. The first thing with Dandy-Walker malformation is that the vermis is abnormal. It's typically hypoplastic or absent. Here, it's not the case. We see it. The second component is CSF expansion that connects to the fourth ventricle. Here, the fourth ventricle is not expanded. It's just displaced. And finally, for a typical Dandy-Walker malformation, you'd have expansion of the posterior fossa and elevation of the venous confluence that we talked about. Another lesion that may simulate a cyst in density is an epidermoid cyst. Sometimes with an epidermoid cyst, you might notice that the fluid is a bit more complex than your typical CSF. Although that's sometimes difficult on a CT scan, it would be much easier to appreciate on an MRI. One of the things that you could do to make sure that there is no abnormal enhancement is to do an MRI with intravenous contrast. The reason you might want to do that is because some posterior fossa neoplasms may have a cystic component. And whatever differential diagnosis we talked about just a moment ago should not show you enhancing components at all. Now that you're an expert, let's look at this sagittal T1 MRI on the same patient. You know that a T1 acquisition would show you CSF as dark, and that's what we see here. This is the third ventricle, opens into the cerebral aqueduct, reaching to the fourth ventricle. And this is your abnormal cystic finding that is clearly separated from the fourth ventricle by this membrane. And the lesion also displaces the cerebellar vermis upwards. The vermis is there, it's not hypoplastic. You could also see that the vein is not elevated upward, the posterior fossa is not expanded, so all that tells us that this is not a Dandy-Walker malformation. As we mentioned on the CT scan, the appearance and the location of the CSF abnormality is not fitting with that of a mega cisterna magna. And on the same patient, this T2 image shows you that fluid is bright in the lesion and is also bright in the ventricular system. On this flare acquisition, which is a modified T2 where you suppress the signal from fluid and fluid appears black instead of white, that the ventricular system is dark and the abnormality is dark as well. So it's following simple fluid signal intensity on all sequences. If this were to be an epidermoid cyst, you'd have a more complex appearance on MR, and on this sequence in particular, which is a diffusion sequence, epidermoid would appear bright. So this is dark, and this is all consistent with an arachnoid cyst. Finally, this is a sagittal T1 acquisition on the same patient after giving intravenous contrast, confirming the absence of any kind of enhancement. And by that, you made sure you're not missing a neoplasm that has a dominant cystic component. So the final diagnosis here is an arachnoid cyst that was incidentally discovered in this trauma patient. For the sake of comparison, let me show you this other example that has a different finding. Now you're an expert, CSF is bright on this T2-weighted image, and you see that there is expansion of the CSF space posteriorly. On this sagittal T1 sequence where fluid is dark, you notice that the CSF is expanded posterior to the cerebellum. The fourth ventricle is normal and it's not expanded. The vermis is complete and it's not abnormal in any way, and this is a case of mega cisterna magna. So let's summarize what we learned from this case. We learned a little bit of anatomy by knowing the components of the brainstem, the cerebellum, and the ventricular system. We also mentioned that if you have a mass lesion in the posterior fossa, make sure you don't have significant mass effect in the form of herniation, such as tonsillar herniation. Always comment on the status of the ventricular system with such abnormalities, since there is a good chance you might have obstructive hydrocephalus. After making sure that the lesion is cystic and has no solid components, by looking at enhanced sequences, you have a classic differential diagnosis. A differential diagnosis of a cystic appearing abnormality in the posterior fossa includes mega cisterna magna, arachnoid cyst, epidermoid cyst, and Dandy-Walker malformation. Knowing the status of the fourth ventricle, the vermis, the size of the posterior fossa, and the location of the veins would help you differentiate these abnormalities. If this was a Dandy-Walker malformation, you'd expect vermis abnormalities and communication with an expanded fourth ventricle. Although an epidermoid cyst could look dark on CT, MRI is useful since it would tell you that the fluid within is not as pure as you think, and an epidermoid would be bright or restricted on diffusion, which is a very helpful sequence for that. With mega cisterna magna, a normal variant, you'd have expansion of the CSF space posterior to the cerebellum. There is more to discuss with the Dandy-Walker malformation, and we'll leave that for another case in the future. Thanks for watching. We'll see you with more cases this week. As usual, your comments are more than appreciated. Hello again with this new case. This is a 69-year-old female patient, and this is a sagittal T1 MRI acquisition. Now there's a specific teaching point that I want to show with this case. Of course, if you have a brain MRI, you're going to look at all of the intracranial structures. However, what I want you to concentrate on is what's outside of the brain, namely the bone marrow. Just a little bit of anatomy. This is the subcutaneous tissue with bright fat. We agreed that fat is bright on T1. We also agreed that the CSF fluid is dark on T1, such as the CSF space you see here. So what's between the CSF here and the subcutaneous tissue there is actually the bone of the skull. In more detail, this is the outer cortex, which is very dark. This is the similar dark inner cortex. And this is the bone marrow, which is contained in what we call the diploic space. So this diploic space is just a fancy word for the marrow that's contained between the outer and inner cortex of the calvarium. Like any other bone in the body, this space contains marrow. As we discussed in a prior case, the marrow contained within the bones could be one of two types, either red marrow or yellow marrow. The vascular red marrow is usually dark on T1, while the yellow marrow, because it contains fat, is bright on T1. As we grow older, the red marrow gets replaced by more yellow marrow, so more fat in the bone marrow. And since the yellow marrow contains fat, it should be bright or of high signal intensity on T1. So in an adult, if you have lots of darkness of the marrow on a T1, you have to think about physiologic or pathologic replacement of the marrow. Now this area of the calvarium appears normal because it's bright on T1. However, let's look at the other areas posteriorly here. So on this T1 image, there is replacement of what's supposed to be a bright marrow by what appears to be dark here. Although heterogeneous, you have to think about bone marrow replacement. The reason I show this could be easily missed on a brain MRI if you don't think about it. A very good location to look at is this bone here that looks like a triangle. It's well seen on a sagittal midline T1. This bone has a fancy name. It's called the clivus. So this clivus is located anterior to the brainstem here. What's peculiar about the clivus is that it's typically a very fatty and bright bone on T1 in adults. So always keep the clivus as one of your checklist points when looking at brain MRIs to make sure that there is no bone marrow infiltration. As you see here, the clivus is heterogeneously dark in some areas, so there is replacement. If you think the clivus, this triangular bone, is not convincing enough, let's look at another area. Although the exam is not intended to look at the cervical spine, we do catch part of the upper cervical spine here. And what applies to other bones in the body applies to the spine as well. Look at this vertebral body, which is the second vertebral body. You could argue that it has a relatively higher signal intensity, denoting normal yellow marrow. But what about the vertebral bodies below it? So this is the C1, C2, C3, and this here is a C4, which is completely abnormal. A very important rule is the signal intensity of bone marrow on a T1 in an adult should never be lower than the disc. I'll show more images on this patient to emphasize this important rule. But before we do that, let's compare what we looked at to normal cases. So this is a different adult, about 50 years old, with a typical normal clivus. A very bright and homogeneous clivus denoting normal yellow marrow within an adult. In this same normal example, let's look at the calvarium. Look at this posterior part of the skull where the marrow is bright and normal. Again, this is subcutaneous tissue with normal subcutaneous fat. This is outer cortex, diploic space, inner cortex, and CSF space. To emphasize the point further, let me show you this lumbar spine on an adult patient of a relatively similar age. A little bit of anatomy. This is the squared vertebral body with its dark cortex and its inner bright marrow. This is the intervertebral disc. And this is a T1 image, as you could tell by the dark CSF fluid. Now, the general rule that we were talking about is that an adult should have more yellow marrow, which is brighter on T1 than the adjacent intervertebral disc. So in adults, if you see homogeneous or heterogeneous infiltration of the marrow by darkness that is similar or more than the disc, that is not normal and denotes either physiologic or pathologic replacement of the yellow marrow by other abnormal processes. So the rule is that the disc should always be darker than the adjacent vertebral body in adults. And the sequence used to look for that is T1, since looking for such findings on T2 is more difficult. Here is a normal sagittal lumbar spinal T2 on the same normal example that I just showed. You're an expert now, you know that T2 shows you bright fluid, and the same anatomy applies. This is the vertebral body, this is the intervertebral disc. The T2 weighted images show the intervertebral disc in a better fashion. Remember that the disc has two components. The outer fibrous component that you see here and here, that is circular and very dark on T2, which is called annulus fibrosus. And the inner central component that contains more water, and that's why it's bright, which is called the nucleus pulposus. Although fat is also bright on T2, which means the yellow marrow would be bright, seeing the water-containing nucleus pulposus, which is bright, makes assessing the signal intensity of the bone marrow on T2 more difficult than that on T1. So when you're looking for such a finding, use the T1 acquisition. Now that we cleared all these facts out of the way, let's go back to our abnormal case, the initial case that I showed you. And this is the sagittal lumbar spinal T1 on that same abnormal patient. On this T1 where CSF is dark, it's much easier to appreciate the contrast between what we saw as normal and abnormal here. The bone marrow appears extremely heterogeneous. Although you have areas of normal, bright yellow marrow, you do have other areas that are extremely dark, even darker than the adjacent intervertebral disc, which is abnormal. Now, if you look at that same patient on the T2 weighted image, where CSF is bright, you could still see the extensive abnormality. However, the abnormality is much easier to detect and appreciate on the T1 image. The final diagnosis on this patient turned out to be metastatic bone involvement from a primary breast carcinoma. Hopefully in the near future, I will dedicate a separate clip to discuss all the causes of bone marrow infiltration. But for now, let's summarize the few points that we could take away for both seniors and juniors. First, when you're looking at a brain MRI, don't forget to look outside of the brain, namely the bone marrow. Areas to look at would be the calvarium, the skull base, and the upper spine, and don't forget the clivus is a good bone to use. Remember that in adults, red marrow is replaced by yellow marrow, which should be bright on T1. Also remember that T2 is not as good as T1 for assessing the bone marrow abnormalities. And the general rule is that on a T1 of an adult, the intervertebral disc should be darker than the adjacent marrow in the vertebral body. For juniors, we discussed a little bit of osseous anatomy of the skull and spine on MRI. Well, that concludes today's case. Thanks for watching. I'd appreciate your comments and see you with more cases later this week.